Thank you for joining our TCTAP 2022 virtual meeting. And I'm going to start the live case session. Coronary live case session 3 is a complex PCI. So I'm going to very happy to introduce and co-moderator, and he's a well-known doctor and teacher and the physician in cardiology, legendary physician in cardiology, and David Holmes from Mayo Clinic. I'm going to introduce the panelists and Michael Lee from the David Geffen School of Medicine and UCLA, and Dr. Toshi Muramatsu, Japan, Tokyo Heart Center. And another panel is Dr. Ong, and from the Hong Kong, the Sanatorium Hospital. And another panel is David Kanjari from Piedmont Heart Center in United States. Okay, David Holmes, can you start the live case session?
Dr. Park, thank you very much for this opportunity. And this looks like we have some very good cases. We talked about with Dr. Wu, who will have the first case, and we're going to talk about those issues on each of the cases that we have learned, those things that we have questions about, and how do we resolve those questions. And so this is a patient, and we'll hear about that, in whom we'll be able to weigh in and discuss issues when it's hard to see the culprit lesion or when there's heavy calcium. And what are the issues that we can do to bring out the fine details of the case. And we'll do that with each of the cases to make sure that we get the teaching points that we try to get out of each of these exciting cases. So, Dr. Park, it's great to be with you on this.
Okay, Dr. Wu, can you start your case?
Good morning, so all the and good evening to all the friends. So I'm very nice to see you online. And first of all, so I think it's thank you organizing committee to invite the Fuwai Hospital to join this very important event. And so I'm Dr. Wu from Fuwai Hospital. So this is the first case. And so now our team, so maybe the Dr. Zhang Hongliang will operate this case. And so maybe the first I'd let the Dr. Zhang and to briefly introduce this case. Dr. Zhang, please.
Yeah, okay. Good morning, dear professors. It's our honor to present our PCI case to TCTAP. First, let me introduce our team. I'm Zhang Hongliang. This beautiful lady next to me is Dr. Zhao Zhenyan, and the gentleman is Dr. Wang Xiang. This patient is a 55 years old gentleman. He presented with angina for about half years. And the angina pectoris exacerbated for about 3 months. Then he referred to our hospital for angiography. About 1 month ago, the angiography showed right coronary artery is severely stenosis. We put a stent to the distal segment of right coronary artery. And this gentleman had a lot of risk factors for cardiovascular diseases, include diabetes and hypertension for about 10 years, and hyperlipidemia for about 5 years. And the routine laboratory test showed a normal test. And the echo showed left ventricle ejection fraction is 63%. And let's see the next PPT for angiography.
This is not moving. This is not moving. Maybe so we can go to the recorded the video.
I will introduce the angiography briefly.
That's fine.
It certainly looks like diffuse diabetic disease in the right and other vessels.
Yes. In this morning, the angiography showed that right coronary artery, the stent is okay. Also, we can see a lot of oblique in the right coronary artery. Next, also we can see the calcified lesions in right coronary artery. From this angiography, we can see that left coronary artery is also severely calcified. Next, please. Yeah, from the epicranial, we can see there is a diffuse lesion across the whole segment of left anterior descending artery. The left main is also severely stenosis, and the diagonal too. The orifice is about 95% stenosis. Next, please.
Can you go back, or this would be a
Go
good
back.
one?
Go back. Go back.
We
回放一下。
see the aneurysm, the local aneurysm,
Yeah.
in the close proximity
Yeah.
to that diagonal branch.
Yeah.
That
yes.
may
Yeah, right.
give you some difficulty in navigating that with a wire.
Yeah, but it's already, so we have already put the Y in the diagonal. So it's really, yeah, so you're right. So it's really difficult for the wiring from the left, from the LED to the diagonal.
Okay.
Yeah, right. So this is the point. Yeah.
Next, please.
And so what wire did you use?
Yeah, it's the BMW. And
Okay.
also it's the one, maybe the one is the local, it's the translocal products. It's called NC. Yeah. So
And
it's
did you bare
so
wire that?
yeah, what?
Did you bare wire that, or did you use a microcatheter?
No. So just the wiring. Just the
Okay.
wiring. So because
Good.
the Dr. Zhang, he's the excellent guy, and
Okay.
he's yeah. Okay, continue.
Yeah. Thank you. We can see from the caudal, the left circumflex, the proximal segment is also severely stenosis, and it's also calcified. The wire across across the orifice of left circumflex, we meet a little difficult, but finally we get the wire through.
So the Dr. Zhang and he performed the wiring in the LED circumflex and the diagonal. He just take maybe the 3 minutes to finish all the 3 wiring. And maybe so we can continue our the slide. Next slide, maybe the last slide. So we will talk about the what we will discuss. Okay, so maybe next.
So I think we are briefly the Dongjin Wu and introduced the briefly patient, the 55 male and the diabetic hypertension, hyperlipidemia. Syntax score is very high, more than 35, and diffuse and the calcified region, as you mentioned, and the propastavid forms. So there is some proximal aneurysm. It's difficult to widen sometimes to the distal part. Also, distal main, severe calcified region and diffuse region. At this moment, I would like to ask the comment, Michael Lee and Dr. Muramach and Dr. Young, Anthony, and how do you treat this patient? Okay, Dr. Lee or Dr. Muramach, any comment for this case?
Yeah. First, I guess I assume, because this is a technical form, we're not going to talk about cabbage, but if PCI is going to be done, what I would first do is just get that LAD addressed. Let's not address the left main distal bifurcation just yet. So what I would do is do some plaque modification of the LAD. If you're not going to do that, I would minimum do intravascular imaging just to confirm, but visually it looks like it needs plaque modification. I would do a preemptive upfront 2-stent approach to the LAD diag. Once you secure that, then you can take your time and do your left main, probably a crush, PK crush, whatever your choice is. I think it's feasible, but I think it's very important to make sure that the LAD is adequately prepared prior to, because you don't want to struggle with that when you have a distal left main that you're dealing with.
Good.
Okay, Dr. Muramach, any comment for this case?
Yes. This is a very diffuse left main evolving severe disease. So of course, the first choice, one of the choice is cabbage. But if I'd like interventions, the first of all necessary to do the root ablation or any other plaque modification before stenting because of diffuse calcified region. If you can do the IVUS findings help us to the decision. And after that, the CV bifurcation left main, I prefer to use the cura stenting, my favorite one. So I'd like to do the cura stenting for the left main, trying to the post dilatation, and where apposition is very important for the left main long-term outcome.
Okay, it's Professor Holmes in the Mayo Center is one of the leading center in the world. How do you decide the revascularization strategy in your center for such a patient?
I think that's terribly important. Those things that we take into consideration are, number one, what's the extent and severity of disease? Number two, we think about the comorbidities. This is a patient with diabetes.
Yeah.
He is having accelerating angina, but it's not rest angina. Number three, we take into consideration the LV function, and we know that the ejection fraction, it's well preserved.
Yeah.
Then the next piece of information is to say, what is the goal of intervention? So that's that winds up, it sounds like it could be a silly question, except there are several components to it. Number one, we tend to view intervention as something to improve quality of life. He's got accelerated angina now for 2 months. And so I think we can identify some strategy to improve his quality of life by treating potentially the most severe lesions or lesion in this setting. The next question that is harder to do is to say, is one of the goals of our intervention to prolong life?
Yeah.
And that's a terribly important part. We do know that, or at least we've known in the past, that in diabetic patients, we prolong life. That's part of the goal.
Yeah.
But also we need to keep in mind that although we talk about prolonging goal of life, there's a lot of life left in this 55-year-old man.
Yeah.
And so that's terribly important because we'd like to give him something that would be as long lasting as we could. And so in a case like this, we would make sure that we've had a chance to discuss those different options and the different strategies with the patient and their spouse.
Yeah, good.
Okay. Dr. Wu, can you proceed? Okay.
Yeah. Okay. Thank you for all the suggestions. I think it's all the questions. So the panelists take all the questions, which is very important for this the procession. So the first of all is the strategy for this case. So I think this is a relatively young man, is just 55 years old, and if he received the bypass because this the 3 vessel disease, so I think the vein graft normally the keep the open the rate about the 10 years, maybe the 17 to 15 to 17. So we quite to delay bypass in 10 years. Maybe so today we try to treat by the PCI, and maybe in 10 years, so restenosis will occur. So that time, I think the patient still have the chance to receive the bypass. And although this patient, he had a very long time of the diabetes, and diabetes is not very well controlled. So because the hemoglobin is still the more than the 9%, but the renal function is still the normal. So I think it's for this patient, we can let him to receive the bypass. We also can treat so this by the PCI. And so from the anatomy of the coronary arteries, so it's a really complex. So it's very calcified and very diffuse from the left main to the middle RAD, and also the circumflex also diseased. So from the view of the PCI procedure, it's a really the difficult, but we try to do by PCI. And so regarding to the PCI strategy, so the first we select the 7 French, the guiding catheter, and so we should evaluate the what part should be treated because it's very diffused, and what's the degree for the procedure difficult. So we evaluate by the IRIS and to check severity of the calcification. And so now we have already finished the IRIS check. So maybe we can show you the IRIS findings, please.
IRIS 上
Did you have trouble getting the IVUS catheter in?
No. So it's the smooth.
Okay.
Good.
Yeah. So
this
IRIS. So from the distal RAD up to the left main. So the very diffuse and also the calcified. And the lumen diameter is maybe the 2.5. Yeah, but so this part. Okay.
Okay, this is the middle LED.
中医你来讲。
Okay, this is the
你
middle
来讲吧。
LED. And we can see some superficial calcification. And here we just get through the diagonal, and we can see the aneurysm here at the 6 o'clock
So
junction.
my colleagues, so the Dr. Sun Zhongwei will talk about the IRIS findings.
Yeah, this is the most stenosis part of the
I can't
LED.
hear. I can't hear you.
听不见。
Is it
So maybe he
diffuse?
can change another microphone. Yeah.
Yes, diffuse calcified region.
Yeah, right.
So this is the pullback from the LED. We can see the LED is not a very big vessel. And
Is calcium was extended from the mid LAD to the the
in
left
the middle
main.
part of the LED, the reference diameter we can see is around 2 or 2.5. And we can see superficial calcification.
So we tend to think that in diabetic patients, there is often negative remodeling.
Yeah.
And so in this man, the vessel looks to be 2 or 2.25. Is that because of the negative remodeling?
Yeah. Here is the aneurysm.
Yeah, it's the aneurysm.
So this is almost the proximal of the LED.
Okay.
This is the diameter in the proximal in this part.
Is almost normal.
Yeah, almost normal. Yeah.
Yes.
Okay, it's a
This is the left. This is the circumflex. So this is the left main.
Could you also check the succosteum, IVUS?
Yes, already. It's already. Okay, so moment please. So we switch to the circle flex.
You know, the IVUS images, I don't see very well. I'm not sure if the issue of gain or not, but it's not very visible.
Yeah, this is from the circle flex. The flex seems better than the LED.
Yeah, this is from the middle circumflex.
Yes.
Yeah. Okay, so this looks relatively normal, but the proximal maybe. Yeah. So now the plaque is the more plaque.
Yeah, we almost get to.
Yeah. So I okay.
Yeah.
Okay.
This is the left main. So I think it's the disease also in the proximal the circumflex.
Yes.
So it's also should be touched.
Yes.
So I totally agree with the panelist, and so maybe the left main should be touched and should be the two stents. And so, but so it's the not questions. So the disease. So what part should be treated? So now because in the last year, so this last year, at the Fuhai Hospital, they just have the one clinical research. It's called Phase 3. So the author is Professor Xu Bo, and so in the last years we evaluate the lesions functionally. They normally use the QFR. So it's the QFR. So we use the QFR to calculate the what part should be the treated. So from this view, can you 钟伟，你可以直接就放到这个 QFR 这张上。So maybe now we can focus on the QFR measurement. So from the left main to the distal RAD. So QFR is the point 4.3. So it's very severe. I think it's the beginning of this procedure. So patient already have a chest pain. So we have already the dilate with the small bone. So now this the symptoms are relieved. So that means so this is severe. And if we put the stent up from left main to the middle RAD, so the KFR will be this part
0.6
is the 0.95. So that means we just put the stent from left main to the middle, to just after the diagonal. It's enough. So our strategy. So first we dilate the proximal RAD and also diagonal. So the diagonal is relatively big. So maybe we depends on the result of the balloon dilation in the diagonal. So maybe we just one stent in that area, maybe two stents.
Are you going to consider, because of the severity of the calcification, an atheroablative approach?
Yeah. So this is a big problem. So maybe we can can we start our procedure?
Sure.
Okay.
Okay.
Yeah.
Go ahead.
So actually, so in the routine, the clinical work. So so case like this, it's really difficult to make the clinical decision. So sometimes we let patient to receive the bypass. Sometimes we try to do by the PCI. But I think this patient he don't like to the bypass. So this thing we try to do by PCI.
Okay. And this is a non-compliant balloon.
Yeah, this is non-compliant. So this because for pre-dilation with the non-compliant, because it's calcified. Yeah.
Okay, the panel, and do you have how do you treat this severe calcified region in your cath lab? Is your orbital atherectomy, rotational atherectomy, or laser is available? How do you treat in the Dr. Muramacho or Michael Lee, Anthony, and how do you treat this region?
Well, I think for me, if I'm doing the case, because from the IVUS, it seems that the calcium is very diffuse, and but most of them is eccentric calcium. But I do think that the calcium is really heavily loaded, so maybe some reduction therapy is necessary for me. Maybe I will put a burr down the LAD to get some reduction of the calcium, and then use NC balloon all the way up to the left main
Mm.
and see. But whether I will put the burr also in the diagonal, I'm not quite sure. Yeah.
Great.
Then, of course, you'll have to unwire the things that you spent some time wiring.
Yeah,
Because-
absolutely. Yeah.
So I think that's when intravascular lithotripsy is very useful when you have a important diag, especially if it was difficult to wire. It does not preclude losing wire access to the side branch if you do intravascular lithotripsy. Unfortunately, it's very device and may not be available in many geographies.
Okay, so now so in our CAS lab, so the routine ablations are already prepared. So it's we just prepared the root ablation, but it depends on the balloon dilation. And another our consideration is the finding from the iris iris check, because although from the angio we find so very diffuse and very it was moderate to severe calcification from a left main to the middle RAD, but iris showing is the calcification is not a circle. It's so in this reason, so we try to dilate with balloon, but now we find that so we use the non-compliant balloon to dilate the lesion. It's not very difficult. So I think it's maybe the root ablation is not very necessary. Yeah.
Okay, Professor Wu, how do you plan to treat the distal limb main bifurcation? Circle osteum also there's some disease. What is your strategy? Is it just a stent crossover, or do you plan to two-stent strategy?
Yeah, sure. I think two-stent. But it's so Dr. Zhongwei, so can you show us the QRFR in the circumflex? Maybe he can measure the QRFR in the circumflex, because if the circumflex, because circumflex is not very small, so I think we should keep it open. And if we put the stent, cross the stent from left main to the RAD, maybe the circumflex will be jailed. So I think that maybe the two stents will be safer.
I think that's correct.
Okay, yeah. So now we can show you the QRFR in circumflex is the 0.64. Yeah.
Great.
And what do you can you give us suggestions for the circumflex at one stent or two stent for the left main?
So is any comment from the panel for how to treat for? So in Assam Medical Center, we just treat the crush technique for this case. Yes. So I'm very interesting to see in the use the QFR based PCI, and you're in the Fire Hospital last year TCT meeting favor 3 China trial published in Lancet Journal, routinely used in complex regions the QFR based PCI. And the 1-year outcome QFR-based PCI is associated the primary endpoint reduction, mainly driven by fewer MI and repeat revascularization compared to angiography-based therapy. Is how many cases you are using the QFR routinely in your cath lab?
Yeah. So I think for the complex the cases, so the QFR is was used usually it's routinely used, especially for the diffuse lesion. So the first we measure the total QFR in one vessel, and so maybe we calculate the segment by segment, so we will know which segment should be touched. So in this way, we try to decrease, use the stent.
I think it's also very helpful to do it after your PCI, because if you have an FF or a QFR of less than 0.90, your higher event rates compared to, let's say, if it's greater than 0.90, then your event rate will be lower. So I think it's also helpful to optimize and not leave residual ischemia at the end of the case.
Okay, thank you. So maybe now we back to the procedure. So
Okay.
the diagonal is already the dilate with the two with the balloon is the 2.0. This is the balloon. So can you see the result after the balloon dilation in the diagonal? The diagonal is the really it's not very small. So we try to protect with the balloon or the 2 stent. 2 stent or just the balloon protection. The gel balloon protection.
Okay,
So-
go ahead.
So you plan on then 2 stents?
Yeah. Normally we use the maybe because this is the proximal diagonal section. But you know, so sometimes the section it's good sign, because after the stents in the main branch, so the diagonal is not disappear. So we just use the balloon gel for the protection.
Okay.
Do you think so?
Okay.
Because the diagonal the diameter the less than 2.0, so maybe it's difficult to stent.
Okay.
Okay.
Go ahead.
Okay. So now we the first we select 2.5, maybe 23 in the left in the RD. 再打一个压力泵，用2.0的球囊作为 gel 啊，2.523对。So 2.5 stent by the 23 and 2.0 balloon in the diagonal. Okay.
Just to confirm, you're going to put a 2.5 millimeter stent in the prox LAD, is that correct?
Yeah, right. Not proximal. They just it's the diagonal segment.
Okay.
Yeah.
You know, in my experience, sometimes you have diffuse disease. I think you underestimate the diameter of the reference vessel. Number 2, nitroglycerin is also very helpful to see what the true reference vessel diameter is. And lastly, in my experience, in that kind of the proximal 1/3 of the LAD, it's uncommon to have a reference vessel diameter of 2.5. I think you also, post-dilated or image afterward. In my experience, in this young patient where you want durable results, 2.5 may be a good start, but I would have a low threshold to go into it probably will be a 3.0 vessel after, you improve inflow and improve outflow. So 2.5 is something that's a little bit maybe somewhat conservative, I would say.
Yeah. So that's right. So, but from the IVUS, so this segment is 2.5. It's because it's another reason it's the catified. So maybe we can use the big balloon for the pre-dilation. Okay, moment please. So I think we should dilate the left main again.
Okay.
And so it may have been 2.5 because of negative remodeling.
Yeah, right. But I think from the long-term outcome, so this relatively small stent, so I think a long-term outcome is not good. Yeah.
I agree.
And another reason is the diabetes. So because the diabetes will have a very it's not good the long-term outcome.
So, Dr. Wu, for the gel balloon technique, will you be inflating the side branch balloon when you deploy the main branch stent? Because there's I've heard that the mainland colleagues has a technique called active transfer of plaque, ATP, that they intentionally inflate the side branch balloon first and then push the plaque to the main branch, and then they stent the main branch with the stent while the side branch balloon is still up. So will you be practicing this kind of technique?
I think it's normally, so I think it depends on the size of the diagonal diameter. So if the very small diagonal, so we just put the balloon for gel. But if there's a big diagonal, so normally we first dilate the balloon in diagonal and then to dilate stent, and the final so dilate stent again. Yeah. Okay, so now because the catchified, so it's the stent is not easy to move forward. So, and Dr. John dilate with the big the balloon.
You are now trying to put the stent for diagonal venture, right? Okay.
So the stent,
severe caution.
It's not good.
Okay, the Professor Yongjin and room number 2 prepare another case, and I would like move to quickly and then come back. Okay? Is it okay?
Thank you.
Okay. Thank you, Yongjin. Take your time. We're gonna move to the room number 2. Dr. the Cafe Duo, and can you hear us?
Okay. Morning, Dr. Park and dear friends. It's a great honor to be invited to join TCTAP live case. And first, I would like to introduce my team, Dr. Yindong, and two are Dr. Wang here. And first, I think Dr. Yindong will introduce the case.
This is a 39-year-old gentleman. His risk factors included hypertension, hyperlipidemia, diabetes, and smoking. He suffered stable angina for 6 months, and 2 months ago, he suffered a non-STEMI, and we performed angiography, and he underwent a stent on the LAD, and there are the RCA CTOs. His left ventricle size and function is normal. Next one. This is a angiography. Next slide. Here we can see the RCA occluded at the very beginning at the proximal, and there's collaterals from bridge collaterals and from left. So we plan to do the RCA CTO with hybrid strategy. Okay.
Actually, this is a very young patient, and 1 month ago we treated LAD, diffused very severe stenosis, 2 stents implanted. And today, can you see the angiogram today? First, I will show you the bilateral injection. Here it is. Can you see the angio, Dr. Park?
Okay, I'll just see the picture, not see yet. Can you show us the?
Show the angio, please.
Yeah. Okay.
Angio,
great.
please. Okay.
Okay, great.
From beginning. We because the young guy, but BMI is very high, so we use the bilateral transradial approach. Left side is EBU 3.75, 7 French. Right side M plus 7 French. And
They're beautiful collaterals.
Beautiful culture.
Yeah,
But
yeah.
it's not that easy. We can see the bilateral and the left side is okay, but some residual stenosis at OM. And we can see some collateral, but not, there is no one is very obvious. A lot of collateral, but not, we can't find a big one, big and straight one. And next. And go back. Okay, here is the bilateral from RAO 445, and we can see it's not a very long RCA CTO, but the CTO segment is located at the first curve. Usually this is a tortuous part, a lot of chap here. And there, the stamp, the proximal cap is clear, but there is no tapered proximal cap. Sometimes it is very stiff. And if we calculated J-score, it's only I think only 1 point, but many chap here. So I would like to listen to the comment and discussion from panelists.
Okay, so if I'm gonna summarize this patient and the experience recent to non-STEMI and the young patient, the 39, diabetic hypertension, hyperlipidemia, and the smoking, and the LAD was only stented PCI as treated the PCI with stent. RCA today target is RCA region. Okay, I would like to hear some comment. And Professor Muramachi, you are worldwide renowned CTO expert. How do you treat in this patient?
Yes, this is a right coronary CTO and a broad type of occlusion. The occlusion length is not so wrong, and we can see some flow, right coronary flow. Looks like antigradary, and maybe that suggests from something chance of the antigrade blood connection, because antigrade right coronary distal parts. But the other side is, do you have an interventional collateral channel? You say not obvious septal channel.
Yeah.
Any other interventional collateral channel from the epicardial? I cannot find it.
Next. Here. This is from our RAO view, and we can see some collateral, but it's tiny and tortuous. You can see also a collateral from circumflex.
The circumflex epicardial, how about it?
You think circumflex is good? Epicardial. Okay, that's one of my choice.
Yeah.
Seems like the middle LAD has some pretty straight collaterals.
Yeah, straight collateral. It looks like straight collateral, but I will show you later. Okay.
It's very tiny, the distal part of the
because time limitation, I would like to introduce our procedure next.
Okay, go ahead.
And the first, of course, it's a short CTO. I think it's an antigrade case, and so this is a XTR. Because hopefully, I hope to, if I'm lucky, I will find a channel or loose tissue to cross this lesion. Next. You see, this is XTR, but when it reached around the distal cap, I think it's in subintimal space. You can see.
Why is XTR?
Yeah, XTR.
Field XTR.
Subintimal space. And I want to ask a question in this scenario, and the panelist and you will do AWE or parallel wire or other option.
Any comment from panel? You know, it looks like a false lumen, and how do you think so?
It does look like a false lumen. Would you leave the wire there and bring them along a parallel wire to go to another place? You know where you don't want to go.
Yeah.
And that might help you to get to where you do want to go.
Yeah, I agree. We can't say it's a subintimal space. Maybe it's in plaque. So parallel wire is an option, but sometimes usually one at this curved part, tortuous part, parallel wire doesn't work. So for me, today my goal is to try to limit the wire in true lumen in intimate space, or at least limited the subintimate space in the CTO segment. So I stopped the anti-grade approach and go to retrograde. And I tried several collateral. You can see the tip injection, and there's no obverse connection, right? And this, yeah, some connection, but it's tortuous. And then next one, I tried the XCR wire, tried the sim black, next, and finally the next. Actually, I changed the two septal, and this is the septal I succeeded. And the tip injection again, and find some collector, but it's tortuous. And this time I used the SO3 wire, and rotate the wire gently, and let it go. And finally, the wire crossed the collateral. But and you can see this is a microcatheter, is a domestic China domestic microcatheter, 1.7 French APT microcatheter, and it can cross the collateral easily. But here the microcatheter is stuck back. And now this is where we are now. And anti-grade is still XCR wire, retrograde or wire crossed. I think now maybe kissing wire is a good option. Oh, and what is your guys' opinion?
So any opinion for the up to the current stage?
But the microcatheter goes smoothly.
You mean what? Microcatheter goes smoothly? I didn't push microcatheter
Okay.
a lot.
Okay.
You mean retrograde or antigrade?
Retrograde.
Retrograde.
Retrograde stuck there and it can't go smoothly.
Okay. All right.
So I stopped manipulate the retrograde gear and back to antigrade. And now I will do the wire kissing and use Pilot 200 because for this tortuous CTO part, I usually use Pilot 200. And it's lucky, and the proximal cap is not very stiff. Sometimes it need me to use CP12 or 820 to break the proximal cap.
Okay, the antigrade approach, which wire now you are using?
Pilot 200. You can see here maybe some stiff tissue. That is why XTR go to the subintimal or plaque. Test, please. Okay, very close. And go to RAO. Definitely, it's two wire in the same structure, but seems like some gap between the two wire. But the vessel is huge, so I will continue to manipulate the antigrade wire. Go back to.
Okay.
Still some resistance here. Test, please. Go. So if I fail the wire kissing, I will do reverse cut in the CTO segment. 没有不舒服吧？
做到不要大吸气。
Okay.
Oh. Good.
Can we? Good.
So it seems
Good,
like
good.
it's already in the
Oh,
true lumen, right?
Nicely
so-
done.
good. Nice,
Yeah.
nice job. Great.
So for this case, next I will change anti-gravity wire to workhorse wire and check
工
iris.
作老师准备。
Good, good. Excellent.
Really nicely done.
When I push the anti-gravity wire, we look at the tip of the wire, and the wire tip there's no deflection, so always means it's in true lumen. 给我来一个那个。
工作老师。
Yes. So we are lucky today because the tissue is very soft.
Good, good. It's Corsair microcaster.
Yeah, Corsair. Anti-grid is Corsair. And retrograde is APT.
I think the term that you
Ours.
used to be lucky is not really very apparable here.
Good. Excellent. Wow.
Okay. The 2O balloon. I use 2O balloon to trap the microcaster. Oh, 16. Please get the iris ready.
Great.
So I will dilate the CTO segment and then show you the iris very quickly.
Yeah, this is a 2.0.
Yeah. 2.0.
2.0. Okay.
Is there any reason why you want to start with a lower diameter balloon after you cross?
I usually use a lower diameter balloon before iris, but after iris check, if I need, I use a bigger balloon.
Great, great.
Tell, please. Okay. I think that the wire is all the way in the intimate space. Iris.
You know, what's helpful sometimes is to give intracoronary nitroglycerin because, you know, these CTOs are not going to be fully dilated. It's just a consideration. It gives you a better reference for sighting as well.
Yeah, so sometimes if after Corsair cross the CTO lesion, sometimes we don't need the iris. But normally there's many complicated CTO cases, always calcified lesion there. Sometimes it doesn't work. For time saving, I use a smaller balloon to dilate it.
Wow. Huge vessel.
Yeah,
wow.
huge vessel.
Okay.
Just put it here, okay? Or
True
further? Here is okay.
Okay, good.
Okay.
True lumen. Whole segment is true lumen.
It's for
4O vessel.
Yeah, it's 4O vessel.
Yes,
Even 5.
Just a huge vessel.
Yeah. always happen in right coronary CTO. So I really agree. One of the panelists said your wire is not in subtimer, intimer. Maybe it's in the plaque, intraplaque. Okay.
This dissection. Okay, true.
Yeah, all the way in true lumen, right? So we can use the very not very long stent. If we do a parallel wire, there is some risk. A parallel wire will make a hematoma and prolonged to distal, and we will use longer stent, or even we can't implant stent today. So after easily antegrade try, very fast antegrade try. So I go to retrograde very fast and use a retrograde wire as a marker and do the piecing wire and finish this case.
Great, great. Excellent.
It's a huge plaque burden.
Yeah. Okay. Okay. You think three cutting is okay? 3-over cutting.
3.0的切割。
3-over cutting. Yeah, because we're very huge plaque here, and you use cutting balloon, and we will make the stent dilated very well.
口上。对，存在到往近的呢，还有点。
That's
I
an
think
interesting rationale to use a cutting balloon for soft plaque. You believe that there's a reduction in TBR by using a balloon?
I think there's still no evidence, but based on our experience after cutting balloon, in most of the case, the stent expanded very well.
I think the stem will expand very well just because there's no calcium. It looks like it's soft plaque, but it's interesting.
Soft plaque or soft or fibrous. I think a lot of fibrous tissue there.
3.5 the
Longest one.
Longest one.
25. This is cutting balloon.
This is a second generation cutting balloon. So the crossability is good. You can see.
So Dr. Muramachi, can you frequently use cutting balloon for CTO region?
Okay, done.
No, I'm not frequently use the cutting balloon because of the no evidence of the data.
Cost is high as well.
Yeah, data is very important. But when we do the first retrograde case and there is no data, we still do that. Done.
Okay, great.
Okay, done. Stent. I will choose a 3 or 4, a 3.5 or 4 stent.
With 3.5.
3.5 longest one, right?
Yeah.
打吧。
拿了36。
And then you're gonna put the stand, right?
Yeah.
Great, great.
Yeah. Before we finish our transmission, I think I can show you the final result.
Okay.
也有点病变。
Okay, could you check the coronary angio and the people moving to another room?
After put stent, okay?
Okay, great.
Okay, 1 minute, please.
Okay, great. Is on
Maybe
the
there's
base.
still some stenosis at the distal part of RCA. I will check later.
Okay. It's on the basis of IBUS, you decide the stent length and diameter.
Yeah.
Okay, great.
So in my team, and almost 100% IVUS for CTO case. And before the CTO start, we use IVUS to find the good entry point. And before stenting, we will check the wire position and choose the stent size and length and decide whether sometimes we can't implant stent, just a pop-up. Yeah, iris is very useful in CTO. 这是个什么
3536的 grid 哈。
Okay.
A little bit. Very 就这样吧，写吧。
It looks like a really good length.
Yeah, this is 3.5.
Yeah.
Okay.
16 atmosphere.
Sure, a little bit, 16. Okay. Let's take a minute, okay? 那个回出一点 ，make it sure there's no bubble.
Good. Excellent.
Wow.
Wow. Big vessel.
It's a big vessel.
Terrific.
Yeah. Okay, thank you.
Okay,
And,
thank you. I think that your case is very informative to the interventional cardiologist to learn how can you treat the CTO intervention in complex patients. Thank you for this nice demonstration, and I hope to see you in the next year in-person meeting TCTAP.
Yeah.
Okay.
Yeah.
Thank you.
Thank you.
Okay, we move to the room number 1. Okay,
So
what was advanced? Okay, can you explain?
Yeah. Okay, so back, continue to back. Yeah, back. OK， 再继续，还得要继续回一个，再继续，我继续回。OK， 继续回。OK， so this is dilator. This dilation of the diagonal. So with the 2.0, and after that, next. So yeah, so we find that this is the dissection, in the diagonal, the proximal, but it's the diagonal is very diffuse, and the diameter maybe it's less than the 2.0. So finally, we decided to just put the balloon for the protection. Next. So because the first stent is not easy to cross, so we use the big balloon to dilate proximal LAD. So after that, so it's easily the stent is very easy to cross to the middle segment. And then we use the 2.0 balloon to gel the diagonal. And the first stent is the 2.5 by the 23. So according to what we have discussed, so we dilate the diagonal balloon and then the stent after that. Okay, continue. So after the very high the pressure, so the diagonal still exist. Okay, and then we dilate the proximal circumflex. So we measure the circumflex with the iris. It's not very big, so finally we decided use the one stent, the crossover RAD to left main. Next. So next. So we measure with the balloon for the lungs. So finally we use the 3.0 by the 25 the stent, and another balloon in the circumflex to gel. Okay, next. So this is the positioning. So finally, yeah. Next. Okay, the high pressure. And next. So we use the big balloon, the 3.5, because the stent is the 3.0. So this is the final result. And so the diagonal and the next. Diagonal and the circumflex still exist. So diagonal a little bit gel, and the circumflex is quite good. And so maybe now I can show you the iris. Please, 钟伟，你来讲一下。
So this is the plaque from the post procedure. So we can see distally we have hot negative remodeling, and we can see a small dissection in the 11 o'clock. Here is the stent. We measure the diameter of stent is about 2.5, and well expanded. So this is the middle LAD.
So although the calcified, so the stent is very circular.
Yes.
Yeah.
So the two-layer stent. We come to the proximal of the LAD.
It's well opposed.
Yeah.
Yes.
Well opposed.
So here is the left main. Protruding to the aorta for about 2 millimeters.
Good.
Okay.
Excellent.
So the mom, maybe now we can measure the LAD with the QRF. 钟宇，你先看一下给。So now after the final result, so we measure the LAD. So now LAD is 0.91, but it's according to the original calculation. So after our procedure, so the QRF should be the 0.95, but now it's the 0.91. So I think it's similar. Yeah.
It was 0.043 to start with, though, right?
0.
Yes.
Yeah.
0.04.
94.
Yeah.
Yeah.
Yeah. So this is maybe we come back to the before procedure. So I can show you the QRF measurement, the before procedure. Yeah. The moment, please.
Good.
It's
Much improved.
0.43.
Yeah. So it's the before procedure. The QRF is the 0.5. But next, if we just to touch the left main and the proximal LAD should be, so after procedure, according to calculation, should be 0.95, but now it's the 0.91. So it's nearly similar.
It's terrific.
Okay, good. So I think this case, one of the highlight feature in the PCI part is the Dr. Wu and actively use the we call JVT is a gelled balloon technique, active gelled balloon technique for side branch treatment. Is panel and moderator. Have you experienced such like active gelled balloon technique for treatment of LAD diagonal or the distal main and suck? And the Yongjin Woo shows a very nice demonstration for active gelled balloon technique. Could you comment on that? The panel or this Michael or the Anthony?
Yeah, I can tell you that it's uncommonly performed in the United States. Practically speaking, also lack of data, but I think we just need to have more experience, but that's currently not our practice paradigm.
I agree.
I think for me, sometimes perform that in vessels of small sizes, small branches, like the diagonal branches, because the purpose is just to keep it open. And I find that gel balloon technique is very useful in that case. But for like left main circumflex, maybe I still prefer a two-stent technique. But of course, Dr. Wu have shown us that the circumflex in this case is also quite small. So I think that's the reason why he also chose the gel balloon technique instead of putting a two stents there.
So I forgot to introduce the one point of the procedure. So and before the second stent, the crossover from the left main to LAD. So first we dilate with the 2.0 balloon to dilate the proximal LAD circumflex, but it's a little bit difficult to cross, to move forward. So that means if I dilate and then we use the two stent, so maybe the stent to circumflex maybe it's very difficult. So finally we decided to use the one stent. So this is another reason. But the final result is okay. So circumflex is not very, it's kept well.
Yes. So one of the interesting points is for last 1 month, I have reviewed the 3 papers. All paper is about the gelled balloon technique, active gelled balloon technique, submitted JAG interventional journal. Because most the paper is submitted from China. Is it booming of the gelled balloon technique in China?
Yeah. But it's in Fuai Hospital, so it's routine used because before, and so. But so today I can't tell you the what percentage of the two stents in the bifurcation dilation. But actually, so recent years, the two stent strategy it's much less than before because of the balloon gel technique. So. And I think maybe we will show you the long-term outcome of one stent with the one balloon gel in the diagonal. So, but at the moment, I'm sorry, I can't show you.
And is my one concern about that during the active gelled balloon technique is sometimes is it any difficulty to remove the side branch balloon after stenting for main branch?
No. It's very rare, so it's easy to move.
Okay.
And but sometimes if the calcified, sometimes it's difficult. But we normally dilate stent with the low pressure, and we will check the diagonal, the branch. What happened if it's gelled totally? So maybe we dilate again, and so then we pull back the balloon in the branch, in the small branch, and then we dilate the stent with the high pressure. So otherwise, if you use the high pressure for the stent, so maybe it's difficult to move.
Okay, thank you. I think time is already done, and congratulations. It's a very wonderful case from Fuai Hospital. I'm sure it's very informative, educational to all of the audience regarding the complex, advanced technique for the PCI, and really appreciate nice demonstration, Professor Yongjin Woo and Dr. Cafe Duo. Also, I'm very thankful to all the moderator and the David Holmes and panel and Michael Lee and Anthony and Dr. Toshi Muramatsu, and congratulations, your wonderful case, everybody. I hope the next year see you in-person meeting, our TCTAP meeting. Thank you. Congratulations.
Thank you again.
Bye-bye.
Bye-bye.
Thank you.